Hello, and welcome to the recovery training for influenza therapies. With the relaxation of COVID public health measures, there's been increasing circulation of influenza, with the possibility of a severe seasonal epidemic because of waning immunity over the past 2 years, combined with ongoing circulation of SARS-CoV-2. Because of this, recovery will now include patients with viral pneumonia caused by flu as well as COVID, with different treatment comparisons for each virus. The trial design allows patients to be randomised in any comparisons that they're suitable for, meaning those where the treatment's locally available and is not considered to be either indicated or contraindicated by the clinical team. For each comparison they enter, they'll be allocated either to the additional treatment or to no additional treatment, with care otherwise remaining the same. This means it's possible to be randomly allocated to all, none, or any combination of suitable treatments. Current comparisons are shown here in the coloured boxes, but these will change as new ones are introduced and old ones are removed. As these two viral infections may be clinically similar, patients must now have confirmed SARS-CoV-2 and/or influenza infection to enter the trial, and these results will determine whether they're eligible for the COVID comparisons, shown here at the top, or the flu comparisons, shown at the bottom, or occasionally both if they have co-infection. Confirmation may be with point-of-care tests, including lateral flow tests, as long as these are performed by a healthcare worker and documented in the medical record. Follow-up remains the same as before, with a single online form completed after discharge, death, or at 28 days after randomisation, whichever occurs first. No new COVID comparisons have been added with the inclusion of flu, and this training is just about the new flu comparisons, labelled here as G, H and I. These consist of 2 oral antivirals, Oseltamivir and a newer drug called Baloxavir, as well as dexamethasone at the usual COVID dose of 6 mg daily. I'll now talk about each of these in turn. Oseltamivir, also known as Tamiflu, is a neuraminidase inhibitor. These are a class of influenza-specific antivirals that have been widely used to treat flu for decades. The viral neuraminidase enzyme allows virus particles to bud from infected cells, and by blocking this action, neuraminidase inhibitors interfere with the replication cycle. Oseltamivir has been shown to reduce the duration of symptoms in uncomplicated flu by around 1 day, and observational studies suggest it may also reduce mortality in hospitalised patients, but this hasn't been properly tested in randomised trials, so its use remains very variable. This comparison is open to patients of any age who are hospitalised with confirmed flu, including pregnant or breastfeeding women. The only contraindication is previous or planned use of a neuraminidase inhibitor for the current infection, either oseltamivir itself or another drug called zanamivir. Patients with liver or renal failure are eligible, and there are no significant drug interactions. Oseltamivir is given orally and is available as a solution for nasogastric use, but cannot be given by non-enteral routes. Treatments for 5 days, but this can be increased to 10 days for immunosuppressed patients at the discretion of the clinical team. Unlike previous recovery comparisons, participants should be provided with medication to finish the course if they're discharged before it's complete. The usual dose is 75 mg twice a day, but adjustment is needed in renal failure, with 75 mg once daily if EGFR is between 10 and 29 mL per minute, or 75 mg as a one-off dose if EGFR is less than 10 mL per minute. Dose adjustments also needed in patients weighing less than 40 kg, as outlined in the protocol. Specific trial stocks of oseltamivir should be used in recovery, which will be available from the hospital pharmacy. The pharmacy manual on the website provides more details about how to access this and other flu therapies. Oseltamivir is safe, and there's lots of experience in its use. The commonest side effects are nausea, vomiting or headache, which occur in less than 10% of patients and are often self-resolving within a couple of days without stopping treatment. Baloxavir is a cap-dependent endonuclease inhibitor, another class of influenza-specific antivirals, which have recently been licensed for the treatment of uncomplicated flu. The cap-dependent endonuclease is involved in stealing a host messenger RNA cap, which is then used to start copying the viral genome. By blocking this, Baloxavir interferes with viral replication. It reduces viral load faster than neuraminidase inhibitors, but resistance mutations can arise during treatment in some patients. As this mechanism of action is independent of neuraminidase inhibition, It's plausible that the two drugs could have additive effects, so they're in separate recovery comparisons, and patients may end up receiving both simultaneously, either because they're randomised to both, or because a neuraminidase inhibitor is being given as part of routine care. Like the neuraminidase inhibitors, Baloxavir has been shown to reduce the duration of symptoms of uncomplicated flu by around 1 day, but there are insufficient data from randomised trials to know whether it improves outcomes in hospitalised patients. This comparison is open to patients aged 12 and over, weighing at least 40 kilograms, who were hospitalised with confirmed flu. This includes pregnant or breastfeeding women, but as this is a new drug, the only safety data in these groups comes from preclinical studies, which are summarised in the protocol. The only contraindication is previous or planned use of Baloxavir for the current infection. It can be used in patients with liver or renal failure, and no significant drug interactions are known. Baloxavir is given orally and can be dissolved for nasogastric use, but cannot be given by non-enteral routes. It has a half-life of around 3 days, so treatment consists of just 2 doses, the first given on day 1 and the second given on day 4. And as with Oseltamivir, participants should be provided with medication to finish the course if they're discharged before it's complete. Dosing is weight dependent. For patients weighing less than 80 kilograms, each dose is 40 milligrams. But if the patient weighs more than 80 kilograms, each dose is 80 milligrams. No renal adjustments needed. Specific trial stocks of Baloxavir should be used in recovery, which will be available from the hospital pharmacy. See the pharmacy manual for more details. Baloxavir has been safe when used in early flu, causing rare allergic reactions but with no other established side effects. Corticosteroids have become standard treatment for patients with COVID pneumonia, following the early results from recovery. In COVID patients receiving oxygen, dexamethasone reduces the risk of dying by around 1/5, although there doesn't appear to be any benefit in hospitalised patients not on oxygen. Corticosteroids were proposed as a treatment for influenza pneumonia long before the coronavirus pandemic, and are sometimes used for this indication, but they've never been properly tested in randomised trials. It may be that by reducing immune-mediated lung damage, steroids produce a similar benefit in flu to that seen in COVID, but given the different pathologies of the two infections, they could be inactive or even harmful. This comparison is open to patients of any age who are hospitalised with confirmed flu and are also hypoxic, that is, requiring oxygen or with saturations of less than 92% on air. Patients with recent or anticipated use of systemic corticosteroids are excluded from this comparison, including those with SARS-CoV-2 co-infection who are likely to benefit from steroid treatment. Corticosteroids can be used in pregnant and breastfeeding women, as well as patients with liver or renal failure. The intervention is dexamethasone 6 mg once daily, given orally or intravenously for 10 days or until discharge, whichever is sooner. So unlike the antivirals, patients are not discharged on steroids. No dose adjustments needed for renal failure. Pregnant or breastfeeding women should receive an equivalent dose of a corticosteroid that doesn't readily cross the placenta, such as prednisolone or hydrocortisone. Details of this and of paediatric dosing are in the protocol. General clinicians will be familiar with the common side effects of corticosteroids and should anticipate and manage these as they would normally, for example monitoring for hypoglycemia in patients with diabetes, or considering gastroprotection in those at risk of ulceration. In summary, although previous winter flu epidemics have caused tens of thousands of deaths and acute pressure on the health service, coming ones could be more severe because of waning population immunity combined with ongoing circulation of SARS-CoV-2. Unlike with COVID, no promising flu treatments have been properly assessed in randomised trials of hospitalised patients. Following on from the collaborative success of recovery, we hope this is something that we can now address. Thank you for listening.